Hi, my name is Peter Pesci, and I'm one of the neurosurgeons at Duke with a focus on brain tumors. And I'm here today to discuss with you a clinical trial that is really focused on patients who have had brain metastases that have recurred after an initial treatment with SRS and/or surgery. And that clinical trial is called REMASTER, which stands for Recurrent Brain Metastases After SRS Trial. I'm currently the national PI for this study, and it is currently open in a pilot phase, both at Duke University and our neighbors down the road at Wake Forest. This will soon be open across the country, however. What this trial focuses on is a novel technology that's been used increasingly over the last decade in patients with brain metastases and primary brain tumors. And that technology is called LITT, which stands for laser interstitial thermal therapy. And what this is a minimally invasive surgical procedure where we often will perform a biopsy at the same time as that procedure. And we can simply exchange that biopsy needle for a laser catheter that fits down a computer guided trajectory through a very small incision and a very small opening in the bone. And that laser catheter can be used under guidance from real time MRI imaging, in which we convert that MRI essentially into a giant thermometer to cook a lesion from the inside out. Where that technology in the brain metastatic arena has been particularly useful has been treating patients who've had radiographically progressive lesions after initial treatment. Now, that can represent radiation necrosis, which is an inflammatory response that can arise many months after radiation, or that progression can represent true progressive disease, i.e., a metastatic lesion that has recurred or failed to be killed by radiation. The beauty of the LIT technology is that it appears to be useful against either pathologic diagnosis. And we are trying to understand how that technology can be best timed with other therapies, where it should be used in our treatment algorithms for patients who have had recurrent metastatic disease or radiation necrosis, and how best to implement this for patients to improve their outcomes. So I'll walk you through that just very briefly now. Here you can see the title again of that trial, Remaster. Again, my name is Peter Fetchy, and I'm the principal investigator. And again, this is currently open at Wake Forest and at Duke, but soon to be open at a variety of institutions nationwide. So, how does that study look? Oftentimes, when patients radiographically progress and we see a lesion enlarge after prior treatment on an MRI, there are a variety of things that we used to do to try to experimentally rule out whether or not what we were seeing on that MRI represented radiation necrosis or recurrence. And to be frank, that MRI is really not capable of telling the difference. Some people would simply treat with steroids to see if the inflammatory response went away, and if it did not, just conclude that this was truly progressive disease and offer increasing therapies. But the short story version of this is that there really wasn't a great algorithm or methodology for treating patients with these issues. This study is really aimed at looking at the role of LIT, which we've found to be quite useful in these scenarios, and again, how it may time with other therapies. So once we view radiographic progression on an MRI for a patient with a known brain metastatic lesion who's undergone prior treatment, we would consent patients for the study, and those patients would go to the operating room to undergo a stereotactic biopsy relatively quickly. That biopsy and doing it early on is quite useful because it provides us and medical oncologists information as to whether or not what we see in the operating room is radiation necrosis or true progressive disease. That distinction is important because in instances of progressive disease, medical oncologists may want to change up systemic therapy regimens with the notion that what has been being used is perhaps not working perfectly. We get something called a frozen, which is a very quick snapshot in the operating room of what we see on the biopsy. Within 15 to 20 minutes, we know whether we suspect the lesion seen on biopsy is radiation necrosis or progressive disease. If it's radiation necrosis, patients are randomized in the operating room to either receive the LIT procedure right then and there or to begin conservative management with medical therapies such as steroids like dexamethasone. The key point here being we don't really know what the right answer is. Should we be aggressive and use this surgical procedure right up front for everybody with radiation necrosis? Or should we give people a course of a conservative medical management therapy and reserve LIT for patients who failed? The other possibility when patients undergo biopsy is that they have something called progressive disease, where there's truly tumor that we see under the microscope. Folks who have progressive disease on their biopsy will undergo LIT automatically on this study. And one of the key questions we have is whether or not that LIT is enough to control that progressive disease, or whether or not we should come back with further radiation, repeat radiation, to add to the LIT procedure to better control disease. And so patients who have progressive disease will undergo randomization following the LIT procedure to either receive immediate postoperative SRS therapy, repeat SRS, within a few weeks of the procedure, or they'll be randomized to an observation period. And those folks who undergo observation will only receive SRS or some other therapy if their lesion progresses after the LIT procedure. Again, an important point here is that nobody in this study is part of a placebo group. All patients receive fully acceptable and standard of care type therapies. The key here is understanding what should be done quickly and what should be done in reserves or held in reserves in instances of conservative treatment failures. We've already begun this study. It's been open for approximately a year and a half, and we've already enrolled a number of patients, dozens of patients between ourselves and Wake Forest, which is why, of course, we're opening that study nationwide. So, what are the goals of this study? What are we hoping to learn? Well, in patients who have progressive disease, where we use LIT plus or minus repeat radiosurgery, we're trying to understand how long does it take for that lesion that we've treated to progress again, something called freedom from local progression. Patients who have radiation necrosis, we want to see if we can essentially get them off of medical therapies quickly after LIT. And so we look at the time to steroid cessation if we simply place patients on steroids versus use the LIT procedure. And of course, steroids have a variety of side effects and can limit the efficacy of immunotherapies. So we recognize that it's a great idea to try to get people off steroids as quickly as possible. Then there are a variety of things that we look at in all of the groups that are more exploratory, things like overall survival, or in the radiation necrosis arm, how long does it take those lesions to progress? Since this is such a small procedure, how well do people do? What's their quality of life after undergoing surgery versus conservative management? How do we maintain their function, things like cognition over time? And then we try to understand what some of the other outcomes are and the relationships between MRI findings and biopsy results, et cetera. Ultimately, participation in this study is not obligatory if you go to an institution that is offering the LIT procedure, but it certainly helps us in the medical field to understand how best to use this and how to understand how it interacts with other therapies that many patients with metastatic lesions may be undergoing. If you're interested in learning more, please feel free to email my assistant, whose name is Marissa Bianchi. Her email is listed here at marissa.bianchi@duke.edu at the bottom of the screen. And we are more than happy to answer your questions, as well as potentially hook you up with the proper institution for you to consider whether or not you may be eligible for a study of this nature. Thank you for your time, and I'm hopeful that we can really make this an absolute standard of care for patients moving forward. Thank you so much.